to welcome Marleen de Bruijne, who is professor of AI in medical image analysis at Erasmus University Medical Center Rotterdam. And prior to that, she obtained a PhD degree in medical imaging from Utrecht University. And then she was assistant professor and later associate professor at the IT University of Copenhagen in Denmark. So Marleen has co-authored over 200 peer-reviewed publications in conferences and journals. She holds 7 patents, and she is a recipient of the prestigious Veni Vidi Vici grants delivered from the NYO funding agency in the Netherlands, as well as the DFF Wyden Awards. She's currently the program chair of the international conference MICAI this year, and MIDL last year and this year as well. And she's a regular member of the program committee of MIDL, MICAI, SPY Medical Imaging, ISB, and IPME. She's the chair of the IEEE EMBS Technical Committee on Biomedical Imaging and Image Processing, and a member of the MICAI board, the ISB Steering Committee, the IPME board, and the editorial boards of Medical Image Analysis, Journal of Machine Learning for Biomedical Imaging, and Frontiers in ICT. Her research is in machine learning for quantitative image analysis and computer-aided diagnosis in different application areas. So Marleen, we are glad to welcome you today and listen to your talk entitled Weak Labels and Adversaries in Medical Imaging. The floor is yours.
Thank you very much, Philippe, for this kind introduction and for the invitation to speak here today. And I want to apologize from the start that I'm not able to attend the entire day due to conflicting obligations. But if you have any questions or want to discuss further on any of this, then please just drop me an email. So using deep learning, we can now solve many challenging medical image analysis tasks as good as human observers can. And here's just one example. The task here was to segment intracranial calcifications in CT scans, which are an important predictor for the risk of stroke. And we couldn't really solve this with more classical image processing techniques, because the shapes of these calcifications are quite irregular. They're very difficult to model. Their intensities and local appearance are the same as the bone that they are sometimes even appear connected to. With deep learning, we can solve these problems now quite easily. And this is just one example, but we've seen many examples in the past few years in which deep learning performs as good or perhaps even better than human observers. However, deep learning requires a lot of representative annotated training data. To give some perspective, as a rule of thumb, Goodfellow and co-authors in their famous deep learning book state that to achieve acceptable performance, you would need around 5,000 labeled examples per category. And to match human performance, you'd need at least 10 million labeled examples. Well, I think this is too pessimistic. Within medical imaging, we have seen excellent results with much fewer training samples. For segmentation problems, sometimes down to as low as 5 or 10 fully annotated images. The example that I showed you on the slide before, the intracranial calcification detection, that model was trained on 1,000 examples, and it performs really well. But we did still see that we made more errors in the larger calcifications, which should not be that difficult to detect, but they are more rare, and they're more rare in our training data. So good models require a lot of training data. And this is a problem, especially in medical imaging, because high quality, annotated, labeled data is difficult and expensive, sometimes even impossible to obtain. So a lot of our research in my group and worldwide is focused on how we can learn reliable models with less data or less annotations. One approach to that is learning from weak labels. Well, what do I mean by weak labels? It's basically any type of label that contains less information than the label you want to predict. And typically weak labels are easier to obtain. For instance, if a task was to segment lesions in these MRI images, strong labels would be where an expert indicates for each voxel whether it's part of a label or not. Weak labels could be, examples could be, there's a moderate lesion load in this image, or there are white matter hyperintensities present, or the number of lesions that is visible in a specific slice. And if we can train our models with these kind of labels, there's a lot of data readily available for us to train models on. There are large clinical studies with such semi-quantitative analyses already performed by experts. There are radiology reports with some limited information on what's present in the image made for many thousands of images on a daily basis. So here's one example of our work in that area. Our task here was to segment or quantify enlarged perivascular spaces in the brain. And that's an emerging biomarker for dementia and for the risk of stroke. And here you can see what these lesions look like. They are very small, bright, elongated structures on MRI T2 weighted images. And I indicated some of them on this slide with blue arrows. And on the left, you see examples here from different subjects, different regions of the brain. On the left with no lesions at all, and to the right with many lesions. And manual annotations of these lesions is extremely time consuming. If there's a large lesion load, this could take up to an hour for a single slice, so hundreds of hours for a single scan. But what they do currently in epidemiological research, image-based research on this area, is that they look at different regions of the brain and they perform a visual score, which is typically counting the number of lesions in a certain region, in a certain slice. So we looked if we could train a model just to predict that number, and that it then will be a three-dimensional convolutional neural network regression model. So we want to predict the number of lesions that observers found in a single slice. We will use 3D regression for this, but with a slightly different architecture. We use pooling operators, so we can afford to have a deeper three-dimensional network, but then we also upsample to the original resolution with skip connections, like the UNet segmentation network, if you know about it. So that we end up with a high resolution attention layer that shows us where the network is looking. And with this model, we had a very good agreement with expert scores. So the performance was similar to the inter-observer agreements. What you see here on the graphs on the right are the associations with risk factors. They were very similar for automated and visual scores. And our automated scores were more reproducible than observers when applied to new images from the same patient taken a few months later. Performance here is shown for a model trained on 1600 scans. We also tried a model trained on 400. Then performance is a little worse, but still good. If we go down in the number of images used for training, then performance will clearly deteriorate. Now, what has this network actually learned? We have shown that it correlates, it can predict something that correlates very well with visual scoring. And that in itself is already useful and may be used to replace the visual scoring in epidemiological studies. But we wanted to go further than this, both in terms of validation and quantification. And that's where the attention maps come in. So if you look at these attention maps and compare them, so the attention maps are on the right for different brain regions here, the original image with manual annotations of perivascular spaces on the left. And you can see that these attention maps, they actually indicate the correct locations for these lesions, except for on the image on the top right. Can I point at it, this one? Oh, I can't point at it. There you will see that our network detected more lesions than the observer indicated. That is because observers only indicated lesions that were larger, further enlarged than 1.5 millimeter, I believe, whereas our network also detected the smaller ones, the only slightly enlarged one. And remember, this network is only trained on a single slice in this region where the number of lesions is indicated. So with that limited information, we actually do get a pretty good quantification and localization of lesions as well. We did a further observer study on this, and we found that indeed the network focuses on the correct lesions. It finds lesions in the entire region rather than in only this single slice that was used for training. It can even discriminate between different types of lesions that may look similar. So this could replace visual assessment in large studies, and perhaps even more important, there's also potential to improve on those rather coarse visual assessments by using the full 3D information from the image and also quantifying shape and volume of the lesions based on these activation maps. I wanted to show one similar approach in a very different problem, which was lung disease quantification. And the task here was to quantify emphysema patterns. And typically that is scored visually by expert observers. You really need to have quite a knowledge of these images to be able to do this. And there's also a lot of disagreement between experts on how exactly these annotations should be done. But typically, they look at different regions in the lung, and then they give a score ranging from 0 to 5, 0 meaning there's no emphysema, and then the others indicating an increasing percentage of tissue that is affected by emphysema. So this is much weaker information than we would get from really manual annotations indicating the emphysema regions, but still provides very relevant information. And there are large databases from clinical studies already with these visual scores. So we wanted to train a network to reproduce these scores. And what we used here was that rather than just using doing a regression to predict the score exactly, we again make this intermediate and attention segmentation layer that tells us where our model found the emphysema. And and there we can encode the knowledge that these labels that we have, they're not just a number, but they actually indicate a relative area, a proportion of this specific lung region. So we can include some prior knowledge about the labels in this model this way. And this model performed consistently better than a regression network. Although I still think the main advantage is that we actually do get these, the localization of the emphysema as well. But it also performed consistently better because we put in some more prior knowledge about the type of label. And this provides an additional regularization for the model, especially in smaller training sets. That is useful. Now, what if labels are not weak, but just bad? So most people will say, garbage in is garbage out. If your training data is not accurate, you will never get a good result. I disagree with that. I think this image beautifully illustrates that if you treat garbage in a smart way, you can still get a very nice end result. So here I have one example of that from work that we did quite a long time ago. So this is not deep learning, but it is AI, it is machine learning. The task was to segment airways in CT scans, and you can do this. The first part of this, it's typically at that time it was done by intensity-based region growing. You start somewhere in the largest part of the airways, and you start adding voxels that look similar until you end up with some kind of tree structure, and you don't really know how to grow further anymore. This gives a reasonable result, but only for the more central, larger airways. But if you use this to train a model, to predict where the airways are in unseen images, and we also let the model know that we're not really certain what happens at the edges of these branches. We don't know whether it grows further or not. Then we can get results that look like this. So you can get much higher quality, much completer results with a fairly basic training set because we have in this training set still many examples. Some examples were segmented slightly better, so we have some examples of smaller airways as well, and that helps us segment the entire tree in new data. I also wanted to talk about a special type of inaccurate labels, and that is the labels on unseen data from a model that is not yet fully converged or that is trained only on a small data set. And then you can use this in semi-supervised learning, that is to learn from not only from your perhaps small annotated data set, but also from unannotated, unlabeled data, which is typically much easier to get. In principle, in theory, we could just download it from the packs from the hospital system, and we don't need any labels. We can use those for training as well. Such coarse and possibly wrong labels you could use, for instance, simply by adding some of those labels, those new surrogately labeled images to your training data and retrain a model. But that's a little bit dangerous because these labels can be wrong. A safer way to use such labels is to only use label consistency. So we don't assume that our intermediate segmentations are correct. They may be wrong, but we do know that the model should output the same segmentation consistently if we get different versions of the same image. And that could be different images of the same patient, or it could be different synthetically deformed images starting from the same initial image. And that is typically what is done. And currently, many semi-supervised learning approaches are based on this label consistency principle. I have some results to show for you there. And what you see here is the segmentation overlap for chest X-ray segmentation. So that's the example I always also used in this slide. What you see here is in the first row, a regular supervised learning. We only use labeled data here. The first row is a regular supervised learning, and the second row uses the same loss, but also uses this segmentation label consistency. And here you actually see that there is already an improvement by just using this label consistency, also on fully supervised data, fully labeled data. From left to right, you see increasing sizes of the training sets. So you see that especially on the left side with very small training sets, we have an advantage here by this regularization of the label consistency. However, if we add unlabeled data as well, then the improvement is much larger. Still, especially when the training set is small, but also in semi-larger training sets, we still have quite a good improvement by using also unlabeled data. So to conclude for this part of the talk, there are many possible ways of reducing annotation workload. Annotations do not need to be perfect. And in some cases, I didn't show that, but we found that in some cases, direct prediction of weak labels may even be better than first estimating strong labels as an intermediate step. Now I want to move on to the second part that I promised you, and that is adversaries in medical image analysis. So it is well known that neural networks can be fooled, and in ways that so you can alter an image in such a way that it's difficult or impossible for the human eye to see that it has been tampered with, but the network will predict the wrong result. So here is a very nice example of this. There was a network trained to predict the label of all these kinds of images correctly. Then you add a little bit of noise, not just random noise, but a very specific type of perturbation. And the images, they still look the same to us. But the network suddenly is extremely certain that these are all images of ostriches. So that's a little bit scary to see. And you could wonder what is the importance of this in a field like medical image analysis. So let me first say a little bit about the principle of adversarial attacks. So there are many different adversarial attacks approaches proposed. But typically you start with an input image and you add a little bit of something that is related to the gradient of the loss with respect to this specific input image. And that means that attacks are most successful if the attacker knows the exact model parameters. Otherwise, if you don't know the exact model parameters, you could train a surrogate model that you think might be similar to the model that you want to attack, and then attack that model with the same gradient approach. So that typically works less good, but we know that attacks do transfer between models and also between data sets even. So what does this mean for medical imaging? What is really a realistic attack scenario? Well, I find this hard to predict, I must say. So what we think is reasonable to assume that the attacker will probably not have complete knowledge of all the network parameters. They will not have access to the exact model, but they can make reasonable guesses of what kind of data was used for training and what kind of architecture was used. Perhaps this is even disclosed, or perhaps you can guess it from related literature. We think perturbation should not easily be observed. Otherwise, there are probably easier ways to attack medical records. And we studied how vulnerable different medical classification models were to adversarial attacks in 3 different application areas. And those were classifying diabetic retinopathy from retinal fundus images, detecting abnormalities in chest X-rays, and detecting the presence of metastatic tissue in histopathology. And here are the results. So I don't expect you to read all of this, but let me try to read you through this. So so here we're looking at black box attacks. So the attacker does not know the exact model, but we do assume that the attacker has access to the same training data and used exactly the same architecture. And the numbers that you see here are the area under the curve for classification. So a low number means that the attacked model performs poorly and the attack was successful. And then you also see the percentage of the original model that was reached by the attacked model. So what you see, first of all, that the performance of all models drops dramatically when they are attacked. When the architecture, and it drops more so, as you see here, when they are initialized in the same way. So this model that was pre-trained on ImageNet data and then fine-tuned only on the same fundus and chest X-ray data, it performed really poorly in the ophthalmology application. The attacked model even had 0% accuracy. Now, when the architecture of the target and the surrogate model are different, then we see that attacks are in general already less successful, but there's still quite a drop in performance in most cases, especially when both models are pre-trained on ImageNet. Now for the effect of changes in the training data. First, again, I want to show the case where architectures are the same. The first row indicates training on the same data set, and the second row, so the first row actually is, the very first row is no attack, then the first attacked row is training on the same data set. The second and third are trained on different data sets, but still subsets from the same larger data set. So still data with exactly the same properties. In all cases, if the attack and original model are trained on the same data, attacks are much more successful. Now, when the architectures between the attacked model and the model that the attack was trained on, if the architectures are different, this effect is less clear. And when both the architecture and the training data were different, but remember, they're still a subset of exactly the same data. Attack models still keep around 80–90% of their original performance. So the performance still drops, but it's definitely not as dramatically as we have seen in some previous papers. In what we think is a more realistic setting. I won't have time to show you details about this, but just to note, segmentation methods can be attacked in similar ways. Although you could wonder whether, if you have the segmentation result, that's so easy to assess whether it has been tampered with. So clearly, the case that I show here, someone who looks at this image would know that there's probably something wrong. So to conclude, black box adversarial attacks can be successful in medical image analysis, but much less so if training data and model architecture are unknown. Pre-training on known databases, so we here used ImageNet, but it could also be a well-known public challenge databases, for instance, for this problem. Pre-training may dramatically increase the model vulnerability, even when the target and the surrogate's architectures are different, and even when the attacker does not have access to the same training data. So these are just points that I think we should be aware of when proposing models to be used in the clinic. I'd like to thank you for your attention, and I'll be happy to answer any questions.